what are the physiological signal in hemodynamic monitoring? First, you have to get a signal from the patient, that is the pressure from the patient, which is sent to the transducer which is in the hemodynamic system. This transducer amplifies and microprocess the signal which is obtained through a strain gauge principle, and this is converted to a digital converter which is displayed in the bedside monitor, and you can record the event which is happening. So, what is happening as a mechanical event comes as a digital display in the monitor through the pressure transducer system. Now, coming to the invasiveness of the monitoring. In case of a critically ill patient, in the initial evaluation, for example, the patient is having diabetic ketoacidosis or is in an hemorrhagic shock or something, in those cases, a definitely aggressive, invasive approach is preferred. But once the patient is stabilized, the less invasive system like an arterial line or a CVP can take over. The most important thing is deciding about the invasiveness of the monitor is where you encounter the patient. Whether the patient is in a stabilized position or his hemodynamic is unstable, or the patient who was stabilized suddenly deteriorated. Where you encounter the patient, you can decide on the invasiveness of the monitoring. And this monitoring helps in assessment of your physiological reserve, whether the patient has adequate reserve. Next is, it judges the effectiveness of the applied treatment. For example, if you have started a vasoconstrictor, whether the blood pressure has come up or not. If blood pressure is very high, you have started a vasodilator, whether the blood pressure is coming down or not. So, it helps in assessing the effectiveness of treatment you apply. And most important thing is, you have to go for an appropriate monitoring. What is appropriate monitoring? For example, the patient is in sepsis. Here, the most important monitoring is going to be your heart rate, systemic vascular resistance and your cardiac output, rather than looking at the arterial line which might have hypotension. By having SVR or a cardiac output monitoring, you can pick up this patient early and you can treat it. So, what is appropriate for one particular group of patient, you should look at that patient. And correct interpretation of data, that is very, very important. Okay. Here, for example, if you put a PA catheter and we don't know how to occlude the patient or do a pulmonary artery wedge occlusion and describe about LA pressure, no point in putting the pulmonary artery catheter. And what are the various variables you can get from pulmonary artery catheter, like systemic vascular resistance or a pulmonary vascular resistance or continuous cardiac output. Those variables should be correctly interpreted. For correctly interpreting, you should know how to use the continuous cardiac output catheter in and out. Otherwise, your data is waste and you cannot interpret correctly. Finally, misdirected therapy. When you need a vasoconstrictor, you might start a vasodilator, or when you need a vasodilator, you might start a vasoconstrictor. For example, if a patient has a HOCM or something and the gradient is high, if you are going to start an inotrope because of low pressure, this inotrope will aggravate the obstruction across the LVOT and further cause the downflow of blood pressure. So, you have to assess accordingly. You should not just go with one variable, one blood pressure or something. You should have an echocardiogram to assess everything and then direct the therapy. You should not go with one variable. So, with regard to invasiveness, this is maximum invasiveness and where the treatment can be initiated in ward, emergency department, operating room and ICU. The most invasive is going to be your pulmonary artery catheter. You are going to put a catheter into the pulmonary artery, bypassing the right atrium, right ventricle and then go into the pulmonary artery. That is the most invasive, followed by calibrated and uncalibrated pulse pressure analysis where you have an arterial line and a central venous catheter. Then comes various non-invasive measurement of cardiac output like transesophageal Doppler, non-invasive pulse pressure analysis, transthoracic Doppler, endotracheal bioimpedance and applied fixed principle. The least invasive is going to be your bioimpedance and bioreactance. This non-invasive monitoring can be used in ward, emergency, operating room and even in ICU provided the patient is stable. But only in ICU and operating room, the most invasive monitoring are being used, that too particularly in high risk patient.